Students, we are starting our second lecture on the discipline of traumatology orthopedics. Today's topic will be devoted to fractures of bones and limbs, classification of fractures, fracture clinics, diagnostics, modern treatment of closed fractures, problems of bone regeneration, not fused fracture, false joint. And a certain number of slides will be devoted to such a formidable injury as dislocations. Dislocations, their classifications, clinic, diagnosis and treatment. So, what is such a fracture? In Latin, fractura. A fracture is a complete or partial violation of the integrity of the bone tissue under a load exceeding the strength of the injured part of the skeleton. So, let's talk to you about the classification of different types of fractures. The classification used in our country is slightly different from the international classification. Of course, no one forbids us to use the international classification, but we are still used to traumatologists about our domestic portion of the classification of Arkady Vadimovich Kaplan, the most famous domestic traumatologist, who wrote a fairly high-quality textbook in the 50s of the 20th century, which deals with a large variety of classified signs of fractures and that eventually results in a full-fledged detailed traumatology diagnosis. And here we will talk about some of the types of classification today. So, fractures are concluded for traumatic ones that occur as a result of trauma, and most often this term is not indicated in the name of the fracture. And the fractures are pathological, which are always talked about if the fracture occurs against the background of any existing pathology. Most often, mechanical effort in this case is applied either very insignificant, which in the absence of pathology would be perceived as quite adequate, let's say, to our healthy body. What are pathological fractures? These are fractures that occur against the background of, say, an inflammatory process called osteomyelitis. A specific inflammatory process, for example, bone syphilis, against the background of oncopathology, for example, either a benign tumor or a malignant type of osteosarcoma in the final gives, of course, damage to the bone substance itself and the risk of a pathological fracture. Various systemic metabolic diseases. Well, let's say we have osteoporosis. We will give a lecture about it with you. This pathology can lead to the development of pathological fractures. What is a fracture? If you look closely at this slide, you and I see a regenegram here and we see a fracture. In the fracture zone itself, they are defined, well, that is, there are certain terms. That is, there are fragments. This fragment will be called proximal, this fragment will be called distal. In the case of the existence of any fragment that is not associated with a maximum or distal fragment, it is said that there is a fragment. And in this case, a fairly large fragment is present here in the picture. Traumatic fracture. Depending on the state of integrity of the skin over the fracture zone, it is customary to divide into closed and open fractures. In this case, it is necessary to clearly indicate the situation that connects the bone wound with the external environment. That is, if you and I have an abrasion on the surface of the skin, and there is a fracture of the bone substance in the depth under the facies, it is customary to talk about a closed fracture and separately there about a scratch, about a superficial wound. If you and I have, and this is not always noticeable and is detected directly during the primary surgical treatment of such a wound. If we have a connecting wound, that is, say, the external environment connects to the bone wound, that is, we have damage under the cat and further deeper than the fascial tissue, and with damage to the soft tissues of the muscle substance, then in this case it is customary to talk about an open fracture. Moreover, fractures can be primarily open when a skin injury, a fast injury, is inflicted at the moment of injury directly by a damaging projectile, and there are secondarily open fractures when, after some time, a sharp bone fragment breaks through soft tissues directly from the inside, facies muscles perforate the skin and we have an open fracture. Well, in this case, the variance of our open fracture with U. Depending on the plane of the fracture, that is, on the line that separates the bone from you and me. Fractures are divided into transverse, that is, in this case, the line runs well almost across the axis of the bone. We have oblique fractures, here it is. We distinguish longitudinal fractures, quite a rarity, but sometimes such fractures occur in some bones. Helical fractures. You notice that the line runs in a spiral. In the epiphyseal zone, it is customary to distinguish T-shaped and U-shaped fractures. This is a fairly common phenomenon in the epiphyseal areas of long tubular bones. Well, here the comminuted fracture is presented further. We have already talked about it, and here in this case it is a lot of comminuted fracture to a large number of fragments present. According to localization, it is in relation to long tubular bones that epiphyseal fractures are distinguished, that is, fractures that occur on the Pisi zone. Here, pay attention, we have a proximal pipic bone with us. The bone of the formation that you remember is called a large tubercle, and in this case we have a fracture of a large tubercle that is torn off. That is, we have a tear-off fracture of a large tubercle, directly fracture of the epiphysis. Metaphysical fracture. The injury is quite serious here, but if you look closely, in addition to the epiphyseal fracture, you see the head is broken. We have a clear fracture along the metaphysis line, that is, the line between the epiphysis and the diaphysis, and in this case you see a fracture with displacement. And the diaphyseal fracture, which you see in the middle third of the diaphysis, then the same humerus bone, we clearly note a fracture with a transverse line, with a divergence of fragments, yes, with a slight offset at an angle. Well, in this case they are talking about diaphyseal translation. Diaphyseal fractures in long tubular bones are usually classified according to their location in a certain third. That is, they always talk about the proximal third, or in this case the upper third, about the middle third, and here is just a fracture in the middle third of the humerus diaphysis and about the lower third or distal third of the diaphysis, well, a long tubular bone, in our case the humerus. Another fairly well-known term in the classification of fractures, which is necessarily indicated directly when naming the fracture. This is a fracture without displacement, and in this case, the prognosis itself is quite favorable and the treatment mechanism, well, assumes in most cases conservative ways of treating such a fracture. And a fracture with displacement. Moreover, the displacement option can also be described depending on which way the displacement occurred. But the very fact of the presence of displacement suggests that this is already a more serious pathology, and in this case this pathology most often leads to surgical techniques for treating such. Types of displacement of bone fragments in fractures, which we talked about. The variant of displacement is possible lateral displacement sideways, and usually this situation is described by a radiologist who records the very shape of the fracture, yes, evaluating the X-ray image. It is customary to estimate lateral displacement by the number of bone diameters. In this case, if we look, we see that the lateral displacement in this schematic picture occurred by a little more than 1 diameter of the femur. Offset at an angle. In this case, the original describes the displacement angle itself by means of transportation. Here we see a shift in length, and there is a kind of elongation of the bone, that is, the fragments diverge. Another of the variants of displacement along the length occurs with shortening, that is, the arrival of fragments one after another. And the variant of rotational displacement is presented here in the diagram under the letter D. In this case, twisting occurs and such fractures most often have a helical character. We talked about this 3 slides ago, and there is a rotational shift. Another form of fractures is quite interesting, which in this case, well, are represented on this, say, X-ray section of the femoral neck is a so-called impaled fracture, in which the force action was directed in the direction of these arrows and the neck itself seemed to flatten. Femoral neck. You see, Yes, our head has directly entered the area where the neck used to be and I'm flattening this neck. This is a so-called hammered fracture. Another of the variants of fractures, which is mainly fractures of the spongy floor, spongy bones. In particular, using the example of the spine, we see such a term as a compression fracture. Compression fracture, that is, a fracture that occurred from compression. Another interesting pathology, which is characteristic exclusively for children. These are the so-called epiphysiolosis. Here, from year to year, I still can't attach a good high-quality digital snapshot here. But the bottom line, I think even in such a not very good picture, which by the way is not presented in the form of a negative about the form of a positive, yes, it is quite clear that we have a so-called soft zone. If you remember, there is a so-called soft zone, a growth zone, which is located in the metaphysical zone, in the zone between the diaphysis and the epiphysis. And in this case, this soft zone is certainly less durable than the ossified areas of the bone. Injury can occur in this place, as if slipping occurs. Moreover, here is a rather serious pathology on the lateral projection in the area of the wrist joint. We see that the distal epiphysis of the radius has shifted and slipped. Yes, we have our own base, that is, the diaphysis zone. This pathology is extremely severe. This pathology is displaced and it occurs, of course, not very often. Most often, epiphysiolosis is presented in such a situation when there is some flattening in one place, that is, a decrease in the thickness of the germinal zone, and in the other, on the contrary, expansion. That is, it opens like a sector. Well, in the classroom we will sort it out with you. I will try to show you such pictures. Another type of fracture that occurs only in childhood is the so-called periosteal fracture. If you look directly at the spelling of this term, well, it may seem that a person made a mistake under a periosteal fracture. Well, you, as citizens who study medicine, with all your desire, understand perfectly well that the resection that occurred in this case, sometimes it is also called a fracture like a green twig, in most cases is due to the fact that the bite mark in the child's bone is much thicker than the bite mark in an adult. And the compact bone substance, represented by the trabecular structure, it crumples. It crumples, it undergoes some kind of deformation, but still the bone itself is held due to a very strong, very thick periosteum. Therefore, there are such bulges of the type as if a fracture of a green twig occurs. You remember, just like the green branch, it is quite strong due to the combined layer of bark, yes? Such deformities with slopes, with, let's say, flattening of the bone in one place and bulging in another, are called periosteal fracture, and this situation occurs only in childhood. Another interesting term that occurs in Kaplan's traumatology is the so-called fracture dislocation. In this case, the situation will be that on this slide it is very beautifully presented, that is, on this regionogram, when we have a two-arm fracture and at the same time such powerful displacements occur in the joint itself, which are characteristic of dislocation. That is, the capsule of the joint is torn, there is a discrepancy between the articular surfaces on its large state. This is called the sum of the fracture dislocation. Fractures are usually divided into simple ones, and in this case they indicate the presence of two fragments. Yes, a proximal fragment and a distal fragment. And there are also double fractures, triple fractures, that is, polypocal fractures, when within the same bone the fracture zones can be located directly away from each other. Now, if we pay attention here to the large tubular bone, more than the tibia, we see that in the proximal part of the diaphysis, a multisplintered fracture is clearly visible. And at the same time, in the transition zone of the middle third to the lower third of the diaphysis, we note a comminuted and at the same time with a helical character fracture. In this case, they talk about a complex fracture. We can say that it is segmental, because there is a piece. In this case, it is probably not necessary to talk about this area as fragments. This is mostly a whole fragment of bone, yes, that is, an argumentative fracture, or we can talk about a double fracture of one bone. A fracture with one or more fragments is commonly called a comminuted fracture. Here in this case, on this radiograph there is a distinct fragmented fracture of the middle third of the diaphysis larger than the tibia. You can see what a big shard is represented here. In the case when we have a lot of fragments, and sometimes, in this case, a fragmented situation. Here, pay attention, a computed tomogram is presented here, in particular, even a 3D simulation of a situation with a multilobed fracture of the distal, well, in this case, the meta of the epiphysis is larger than the tibia and fibula. Here we can talk about a multifractured fracture or a fragmented fracture. A huge number of small fragments. Fractures within one anatomical functional formation are called isolated fractures in two or more functional formations there, that is, well, let's say in several limbs or in several segments of one limb, they say. In this case it is customary to talk about multiple fractures. Yes, if we look at it here, we will notice that we have cervical damage on both sides. Yes, here, and here. That is, we have two femoral bones, right and left, broken in their proximal parts. This indicates a multiple translation. Another interesting term that is not commonly mentioned in the diagnosis, but at the same time it is extremely important for a practicing traumatologist. Peony is usually divided into easily held, sometimes they are called stable fractures, and hard to hold, that is, unstable fractures. What is the essence of this topic? Forecast. It is the prognosis and methods that we will use to treat this fracture. Here, pay attention, a transverse fracture of a long tubular bone, in this case the femur, is transverse. In the case of its qualitative reposition, we can say that it is an easily retained fracture. With the help of external mobilization methods, for example, with a plaster splint, we can ensure that we do not need additional fixators, we do not need to perform surgical treatment. It will be quite enough that we will qualitatively immobilize this limb, and after some time we will wait for the fusion of this fracture. Another type of fracture, pay attention, helical fracture of the lower third of the humerus diaphysis. The fracture zone is oblique. The fracture is helical. Even having qualitatively rehearsed such a fracture, in the final we can get the following, and we're mobilizing outside. After some time, the muscles tense up and we get a secondary displacement in the final. It will be very unpleasant. Therefore, these are unstable, hard to hold fractures, most often they are mentoid, oblique fractures, these are comminuted fractures. They are still accepted to operate with the help of external fixation methods. In this case, you can apply intermediality synthesis by pin, or bone synthesis. Now we will talk with you about the methods of treatment to fix such a fracture. The fracture is difficult to hold. Another variant of the classification of fractures depending on the mechanism of injury. Again, in this case, it is not important in the name of the individual, but it is critically important when we assess the situation of psychological data, when we record a protocol injury. So, it changes its mind from bending, and most often in this case we will get an angle offset with you. A fracture happens from a direct blow, and one of these types of fractures, for example, is a bumper fracture, when the bumper of a car hits the middle third of the tibial diaphysis. The fracture happens from twisting. If, again, he pays attention to the same tibia, when a person slips, and the foot remains fixed somewhere on some fossa. As a result of the twisted, we get most often a spiral-shaped alley, a fragmented alley. Well, if you go back to the bumper fracture again, if the action occurs when the car hits at high speed, a high-energy injury. In the final, we can get a large number of fragments of him in the fragmentation zone. And a fracture from compression, when physical force acts directly on the axis of the bone. Another interesting classification, which in most cases by many doctors, far from traumatology, well, somehow either hushed up or misinterpreted. And many ordinary people, very far from medicine, do not recognize it at all, and most people find it very difficult to prove that a crack is also a fracture. So, fractures are divided into complete ones, and if we consider the reactogram, we will find that the fracture line, here we have nothing to show. The fracture line runs from one cortical, that is, the outer layer, to the other side. Yes, that is, it completely crosses the entire thickness of the bone. And also the fracture is not complete. In particular, if the fracture line reaches less than half the thickness of the bone, they talk about a fracture. If it is longer, but again still does not reach the opposite cortical layer, that is, the opposite of the ossicle, then they talk about a crack. There is an option in pressure, when directly, mechanical shocks occur most often and there is pressure on the bone substance. And there is such a variant of cracking of the bone substance. Again, the mechanism of injury is very similar to pressure. In this case, the lines diverge directly in the star form from the area where, say, they were hit with this hammer. Another important thing you need to understand exactly. From a clinical point of view, the fracture itself is not only bone damage. That is, with all the desire, it is definitely damage to nearby soft-woven formations of organs, systems, and so on. Moreover, both directly due to mechanical damage at the time of injury, and due to the fact that displaced bone fragments in fractures with displacement can damage nearby soft tissue formations. What can be an example here? Muscle tissue definitely suffers. Definitely torn, damaged tendons, ligaments. Damage to more serious structures is possible. That is, any fracture essentially damages the blood vessels. All this leads to the formation of intermontal hematomas. A fracture of the femur, for example, is quite adequate when we have a blood loss of 700 to 1000 milliliters. Pelvic fracture, it gives a much greater blood loss, up to 2.5 liters. So, in addition to damage to just minor, but dangerous in terms of blood loss of blood vessels, damage to highways is possible in case of damage and oversawing. And such serious injuries definitely fit the diagnosis. That is, when a diagnosis is formed in terms of classification, it necessarily adds a situation with damage. Let's say if there is a hip fracture, there is a femoral artery. The same situation sounds with the main nerves. Unambiguously, damage to these nerves is recorded and diagnoses. Let's talk about the clinical picture of fractures. The signs of a fracture are presented here on this image. They are divided into probable and reliable. This information is still familiar to you from the time of the 3rd year. In the scope of general surgery, you have passed it. So, the clinic. Probable signs. In most cases, we can meet the same signs with any mechanical injury, let's say with a bruise. Therefore, they are called probable. So, this is a pain. Pain, of course, localized directly at the site of the fracture. Pain that can have quite a powerful intensity. Pain, which may be permanent, or it may be periodic. But by itself, either the moment of pain intensification, or the variant of periodic, say, its appearance is clearly associated with an attempt to move. In addition, soreness. Soreness during palpation in the injury area will definitely be present. This is a fracture clinic. The disease can be caused by pressure, for example, along the axis of the limb, when some kind of mechanical irritation occurs directly in the bone fracture zone. Pain can, more precisely, soreness, can be with percussion pounding on the bone either throughout it, or directly in the injury zone. Swelling, which is most often referred to with the term edema. Edema is definitely present in the area of mechanical injury. This is unavoidable with any mechanical, say, damage. Deformation. Perhaps many people will think that the deformity of the limb could probably be attributed to reliable signs. Here it should be borne in mind that this edema itself is sometimes so powerful, so strikingly deforming the contours of the limb, that the deformation itself is not something that can be reliably said that there is a fracture. Violation of functions. As with any injury, of course, it will be present. Unambiguously, a superficial injury in the form of bruises, sprains, ligamentous injuries will give us a less vivid violation of function than a more serious injury, which is called a bone fracture. Violation of functions in the bones of the skeleton will manifest itself in the form of violations of the stat of the dynamic function, and if we take with you, for example, the upper limb, namely the hand, violation of the function of grasping and holding. We turn to reliable signs of a fracture. There are two of them. Reliable signs can be considered. This is the crepitation of bone fragments. Perhaps, fortunately, they are not so common, because these are all reliable signs. They cause an extremely powerful pain component to a person with all their desire. Therefore, it is often difficult to hear the crepitation itself, because it can also be drowned out by the patient's moans. Plus, meditation, with all the desire, is actively heard only in those parts of our body where the bones are not covered by a sufficiently powerful muscular, let's say, component. For example, the same mutation in the hip joint is extremely rare to hear, because in most cases thick muscles do not allow this matter to be heard. Pathological mobility of the limbs in an unusual place. This is the thing we can essentially compare with deformation. Only this kind of deformation, when the limb is curved in a place where it clearly should not have been bent, and can be counted as a reliable sign. An example of this is the following slide. Pay attention to this slide. You have noticed that the limb is clearly curved along the axis and is clearly curved in the wrong place where we have a joint with you. Definitely here we can talk about a fracture. There is already a fracture even with an offset, because it is clearly visible. Let's talk about additional methods. If before that we talked mainly about physical diagnostic methods, then a few slides are literally about additional diagnostic methods. And the main method, of course, is X-ray examinations. Moreover, under the word X-ray studies, several techniques are currently used, which are widely used. Of course, on the one hand, they require some certain complexity and expensive equipment, but on the other hand, they are very well known to everyone and ordinary people in the face of patients and all doctors. Radiography. Radiography is a technique that allows you to capture our bone skeleton on film. And in our modern time, if you pay attention to the equipment presented here on the monitor screen, that is, in the form of a digital carrier. Therefore, at the moment we meet analog devices that work on the principle of a conventional camera and film and digital cameras, that is, digital X-ray machines that work on the principle of a digital camera. On the lower right layer, please note, an interoperable X-ray complex is presented here, which allows you to engage not only in radiographic research, but also in what can probably be designated as fluoroscopy. That is, live directly online. We can celebrate, well, let's say our actions with you in terms of the reposition of bone fragments. Yes, we can observe directly online how we carry out the procedure of immersion osteosynthesis, for example, intermedular osteosynthesis. The appearance of such devices has led to a serious revolution in the field of surgical techniques and techniques of traumatology, orthopedics, and has significantly improved the outcomes and results of our treatment. Another powerful radiological technique, modern, actively developing, is computed tomography, which originated somewhere in the 70s in parallel with the advent of personal, say, electronic computing systems, serious software products. Now it has been reborn into a powerful diagnostic tool that allows us to almost completely recreate the picture of organs, tissues, well, in particular, like any X-ray method. The method allows you to see a dense formation well and qualitatively. Here, pay attention, in the center of the top we have a slice. A section of the spine in terms of computed tomography, where a compression fracture of the vertebra is clearly visible. And at the same time, on the right, from above and below, we already see 3 arcs. That is, when the scanner made a lot of slices, these slices were combined into a single whole by the software product. Excess or obstructing soft tissues were removed programmatically, and in the final we left only the bone formation to be seen. Well, at the top we find with you a shoulder blade and a fragment of the humerus, and in the lower part you see a skull fracture. Yes, in particular, a fracture of the left zygomatic bone, the left upper jaw, and so on. Another interesting tomographic method is the method of magnetic resonance imaging. Around the same years appeared, well, a little earlier, somewhere in the 60s, everything is in the desire. He continues to develop, continues to improve. The method, of course, is interesting because with the help of magnetic resonance imaging it is very convenient to diagnose and consider damage to soft tissue components. What X-ray techniques unfortunately cannot see. This is damage to the ligamentous apparatus. Please note, in the upper left corner there is a knee joint, on which we can see the presence of even minor ligament damage, whether it is in the same knee joint of cruciate ligaments. Until the appearance of the magnetic resonance imaging, it was based on only hypothetical methods. At the moment, these are fairly reliable, high-quality methods, not the cheapest, like computed tomography, but they have been actively used recently and are being used more and more widely. Ultrasound diagnostics can also be attributed to additional diagnostic methods that are used in tomography, in traumatology. Yes, I do not dispute, we have tried to look at bones and bone damage. We tried and realized that of course X-ray techniques are more accurate, but the accompanying moments of pathology are damage to the vascular apparatus, traumatic release in the area of the fracture itself. These techniques allow you to see very well. Neuromyography, presented with us on the right, is an interesting technique that allows us to assess the functional integrity of the nervous system, which, as we said here a few slides above, quite often suffers from trauma with us. Another specific method of additional diagnostics, well, in this case, probably not so much in traumatology as in orthopedics, are radionuclide diagnostic methods. Whether it is radionuclide scanning, or currently more advanced options for using a gamma camera or using PET technology. Yes, as pure traumatology, of course, it is impractical to use such specific, so expensive and probably not the safest methods. But the breaking of orthopedics of this technique allows you to do a lot. By itself, the diagnosis of skeletal tumors is a very complex topic. We will have one lecture dedicated to her. It is quite complicated both in terms of understanding the clinic and in terms of, let's say, accessibility of the place where the tumor begins to form. So, X-ray techniques do not always allow this to be done in full. But radiological techniques are very good. Yes, there are a number of special radiopharmaceutical drugs that have, I cross out, tropicity to the bone, which are guaranteed to try to accumulate directly in the bone. And, accordingly, in this case, if they accumulate in the bone damaged by the tumor, this allows you to clearly localize this tumor. We continue. And the next part of our lecture will be the topic of fracture treatment. Here, pay attention to this slide. Here with you and me, the treatment of fractures is divided into three most serious stages. The first stage is the pre-hospital stage. Literally 2 words. This is the part of our medical knowledge that each of the medical professionals should be able to know and understand. You, studying medical business, in most cases will not become traumatologists. This is one of many traumatology, one of many disciplines, where our, let's say, graduates will go, that is, you are students. But even working as a therapist, dermatovenerologist, with all your desire, before the hospital stage of providing assistance to patients with injuries, you should know and be able to perform these techniques. That's how I had to stop. We continue. The second stage of providing assistance for fractures is the provision of specialized trauma care. We discussed the structure of this assistance at the last lecture with you. Now we will talk in more detail about specialized care for fractures in the framework of this lecture. Well, the third stage is the stage of rehabilitation or the stage of follow-up treatment in outpatient conditions by an outpatient traumatologist and the stage of restoration of functions using rehabilitation methods, physiotherapy methods, kinesiotherapy methods, and so on. So to the hospital stage. The goal is to provide first aid, ensure the safety of vital functions of the body and properly transport patients to a specialized institution, whether it is an outpatient facility. We discussed the situation with you at the last lecture that there is a special institution called emergency rooms. Yes, or in an institution of a stationary nature, that is, the emergency room of the hospital, where there is a trauma department on duty. The pre-hospital stage is divided into 3 large substages. The first is the essence of anesthesia. With all our desire, you understand, any injury is accompanied by a pain syndrome. Therefore, adequately, within our capabilities and within the intensity of the pain syndrome, and we need to assess the intensity with you, medical professionals, we must perform pain relief measures before we begin to transport the patient. Our potential is not so great. Here the wedding is presented in the concept of non-narcotic analgesics and narcotic analgesics. In fact, access to narcotic analgesics is present only, probably, with emergency doctors, well, in those very emergency rooms of trauma hospitals. That is, if we have an ambulance crew, if we have a very serious injury, we will admit the hip, and the risk of traumatic shock, of course, non-narcotic analgesics will be used. In all other cases, we have access only to non-narcotic, that is, to a group of non-steroidal anti-inflammatory drugs. Probably the drug of choice is to prescribe ketorol. Ketorol is quite cheap, available, there is a parenteral form, there is an enteral form, plus even from the enteral variants there is a fast enteral form, a sublingual form, when the tablet resolves under the tongue. I will not expand further. I think each of you understands that depending on the intensity of the pain components in our trauma, we apply one or another form of analgesia. Transport mobilization. Here we can talk about transport mobilization in a little more detail on the following piles, when a number and a set of funds for transport mobilization. Well, in particular tires. Here is the first and second slide, which we will see now, will be devoted to tires which probably have not sunk into history, but at this time we may not meet them very widely. To know what it is, to know how they work, we still have to. The Dietrich's tire. A large, heavy tire, made of wood, which fixes the lower limb extremely qualitatively. Moreover, the entire lower limb, starting from the hip joint area and ending with the foot. This tire is very difficult to apply. It is big, I say again, heavy, consisting of several fragments. One of the fragments is located from the armpit to the foot, the other stretches along the inner surface of the thigh from the perineum also to the foot, and this splint allows you to fix the entire lower limb. Where can we meet her now? Old ambulances based on UAZ cars, and most often this is a rural area or an area where we have hard to reach regions. This is army medicine, this is the laying of civil defense and in case of emergencies, which are present either at large enterprises, or in large medical institutions, or in evacuation points, which, well, probably in every major city exist in the form of bomb shelters, in the form of such certain, I won't say secret, but very peculiar institutions supported in case of emergency situations. That's where such a tire is present in the Sterlings, so we can still meet it and, well, God forbid, but we still use it. Kramer's ladder tire. The tire is made of steel wire. Here is presented in these pictures. The tire is quite convenient because it can be modeled. It can be folded one with another from the third. It can try to fix the upper limb at different angles, in different, let's say, positions of the upper limb, the lower limb. Therefore, this tire is extremely convenient. It is not cheap, and now you can also find it not everywhere. At the moment, universal tires are widely used. Tires are made of cardboard, or from polymers, from plastic, with which ambulance crews and outpatient polyclinics are now supplied, somewhere well supplied, somewhere poorly, but in this case a set of universal tires suggests that we can mobilize the upper limb, the lower limb. Depending on the size of these tires, we can mobilize a child, we can mobilize an adult who is not very dimensional, let's say, of his indicators, or a sufficiently large adult. Well, here is a number of them presented both in cordon design and in plastic design. Quite interesting tires that are not widely applicable. Sometimes they have met before, sometimes they have already started to abandon them. These are pneumatic tires, which you do not need to forget about. Very peculiar designs that also allow you to perform mobilizationized mobilization. Well, pay attention, here even on the Ukrainian move it is written Pashadopu for fractures of the kinσili, yes, limbs. And quite good pictures that show how you can use wood, banal boards, slats to ensure the mobilization of the entire body, the upper limb, in particular the forearm, the lower limb. We must not forget that the lower limb can be fixed one to the other. The upper limb, here on the next slide we will see, can be fixed with a Deso bandage, and we need to remember how it is done to all of you, and a kerchief bandage. Well, here is a Deso bandage which ensures the fixation of the shoulder, upper arm, and the maximum part of the forearm. Convenient enough. And for those who probably won't be able to do it, the headscarf bandage is very difficult to perform. RTCs, widely and quite actively entered into our lives, are not very well painted in the textbook, because textbooks are still outdated. But these are mostly means of non-transport mobilization. In most cases, orthesis is a means of therapeutic mobilization. They are sometimes much more convenient than traditional means of mobilization, which we will talk about a little later, about plaster mobilization. They cost a certain amount of money, are sold in specialized orthopedic pharmacies, but in most cases they make life easier for the patient, make the quality of life of a sick, injured person somewhat better. Well, pay attention, Here are RTCs for the cervical spine. A soft artèse, called a charms collar, a harder artèse, which is called a Philadelphia-type collar. We will talk about this in classes on spinal injuries. A corset. The corset is rigid, quite powerful and heavy, but also orthoses on the lower upper limb. When considering the issue of patient transportation, when considering the issue of transport mobilization, it is definitely worth talking, of course, about patients who cannot move independently. And in this case, an important aspect is the moment of using the stretcher. Please note, here is a very interesting mistakenly located, say, picture in which a person located in the Volkovich pose, that is, in the frog pose, clearly with signs of a pelvic fracture, because this is the only way to lay a person with a pelvic injury. We will arrange it on a soft stretcher. The approach is probably wrong, yes, because we remember that soft stretchers are not used for pelvic and spinal injuries. At the moment, universal stretcher tires are increasingly being used by both rescue services and ambulances. They are presented here on the left side of the slide. This is a fairly cheap design, made of foam plastic with a large number of holes, which allows you to lay the patient on this shield. Through these holes it is possible to fix it with belts if transportation is not supposed to be very gentle. Allows you to take this shield together, 3, 4. You can see in the area of the head end there are slots that facilitate the option of lifting and loading this bill or that universal stretcher tires into the car. Let's talk about the second stage of providing assistance for fractures. This is the provision of specialized trauma care. As it has been said more than once, most of the bone fractures, as we said at the last lecture, do not require surgical techniques, and the treatment used in this case is conservative. Treatment is carried out in first aid conditions in a trauma center or a hospital emergency room, where there is a traumatology department, and the distant procedure is carried out either in the traumatologist's office on an outpatient basis, or again in the post-treatment room at trauma centers. What does the provision of specialized care include? We will now talk about outpatient care and talk about serious fractures that also require surgical techniques, that is, inpatient treatment. 3 main components. This is the first, if necessary, the reposition of bone fragments, that is, the restoration of the correct position of bone fragments. The second point, it is mandatory. This is the retention and creation of immobility of its non-fracture, as well as the retention of matched tail fragments. That is, the correct and mobilization. And the third point is more, of course, pharmacology. This is the use of means and methods that accelerate the formation of a callus, that is, accelerating our rotation, and if we use the medical term, bone consolidation, that is, consolidation. So, reposition, what is it? This is a comparison of fragments. It consists in eliminating their displacement and in their exact comparison along the fracture line. Accuracy in this case, of course, is a relative thing. Ideally, of course, complete separation. But even a comparison with small defects, with all the desire, most often has very good consequences in terms of a person's recovery. What does the whole thing look like? That is, there is a single-stage manual, or less often, previously widely met, now less and less, hardware reposition with subsequent external immobilization. If it is impossible to perform a simultaneous manual reposition, let's say we have a fracture of the lower limb with a very powerful muscular component in the patient. That is, with all the desire, the traumatologist's hands will be weaker than the legs of the injured patient, yes, then the method of permanent or forced skeletal traction is used here. In this case, we are gradually and slowly implementing this very reposition. And in cases where it is impossible to perform a reposition, in cases where it is impossible to provide fusion to such a fracture, there is the concept of a functional method of treatment. The thing is quite palliative. We will analyze it in the classroom when we undergo fractures of the proximal femur, in particular a fracture of the femoral neck. That's how it will be easier. So, a one-time manual reposition. What is the essence of this process? The reposition itself is quite a painful event. Therefore, it is definitely necessary to take care of thorough and proper anesthesia when performing such actions. Well, in this case, we can use either local anesthesia with the help of local anesthetics, or in the case of an alleged large pain syndrome, that is, pronounced, or the inability to provide complete anesthesia with local anesthetics, then we will use general anesthesia or anesthesia. Local anesthesia is possible both directly in the fracture zone, but here it must be said that the injection of local anesthetics into the hematoma itself, which is formed in the fracture zone, it will not give full anesthesia. Therefore, it is definitely worth thinking about performing, say, anesthesia of nearby soft tissues, that is, local anesthesia, that is, performing infiltrative anesthesia, and if possible and able, then conducting anesthesia. Otherwise, we use completely more powerful either spinal anesthesia, if, for example, this case concerns the lower extremities, or anesthesia, that is, general anesthesia. After that, the reposition is carried out. Yes, simultaneous manual reposition assumes that the doctor is under the control of his own feelings. Yes, with the use of certain techniques, the delivery of bone taps is performed. Hardware reposition. Well, here it is presented in old pictures, old diagrams of the hardware reposition technique. Recently, well, it is being used less and less often, because it does not always give a high-quality result. And a one-stage manual reposition in the final stage will still end with the implementation of immobilization, that is, subsequent external immobilization. Yes, this is probably already. We are smoothly moving on to the second part of our provision of specialized assistance. The traditional means for carrying out external mobilization to this day is a plaster cast. If you remember, in our country, the same Nikolai Ivanovich Pirogov began to use plaster castings to immobilize fractures. It was in the middle of the 19th century. More than a century and a half has passed in our country. To this day this method has not lost its significance. It is most widely used as a method of using hardening dressings. Well, with all the desire, during the summer practice and in the classroom, we will sort it out with our body. Options for plaster bandages are presented here, but first you need to clearly distinguish the terminology. There is a concept of a plaster splint. When we form here on the bottom left, you see, it is represented. That is, a certain thing that is located on the outside of the limb, repeats its contour, has certain dimensions of location. After its hardening, the plaster splint is fixed to the limb using a conventional soft screw bandage. This bandage can be changed. It can be simplified by, say, becoming tighter. If it presses, it can be dissolved and, well, let's say the fixation is repeated. It is estimated in this case that we will talk to classes and mobilization on the principle, that is, our consistency. If the splint is broken, dangling, then they talk about the need to replace it. In addition to the splint, there are plaster bandages. Well, the simplest example is a circular plaster cast. That is, after some time, when we observe a drop in edema and there is no risk with the pressure of soft tissues, we can fix it with a plaster pint around our splint bandage. All this will be heavier, stronger, firmer, and more reliable. Recently, more and more modern, let's say, materials have been used in medicine and, in particular, polymer mobilizing bandages have begun to be actively used. They are made of various chemical compounds. To be honest, they harden from the same thing as a plaster cast, from moisture, that is, from water, but they have a number of serious advantages. Well, on this slide, pay attention. 8, say, advantages of polymer dressings are presented. Starting from the strength, the fact that they are really much lighter and stronger than plaster casts. They are more X-ray transparent, not fully of course, but it is much easier to see the fracture lines on them, to see the stages of fusion and consolidation. They are more hygienic, moisture resistant, they are elastic. This is probably their most important quality. Well, with all the desire it is more comfortable. Strange as it may seem, but chemical compounds based on polyphenolic resins and so on are less toxic and less allergic than traditional gypsum. Because with everything, in my experience, I can tell you that quite often there are reactions to gypsum in the form of dermatitis, in the form of various variants of vocal allergic processes. The strength and lightness of the material. 4 to 5 years is several times easier than this, than gypsum mobilization. Quite a serious thing, especially if we have the mobilization of the lower limb. Sometimes a circular plaster cast on the lower limb can correspond to it being 5 to 6 kilograms, and really moving with such a weight is extremely difficult. X-ray transparency, another one of the remarkable properties of polymer stabilizing materials. Here, pay attention to this illustration. On the right is a radiograph of not the best quality, but I think it will still be clear where the embolization was carried out with a traditional plaster bandage. The quality is not the most pleasant in terms of viewing the fracture zone. In the middle it is fiberglass. These are, say, polymer materials of the last generation. And on the left side, these are modern polymer curing embolizing materials, that is, polyester. Note how different the possibility of X-ray transparency is in this case. The following positive features: moisture resistance. For the banal layman, in many cases this is really the most important thing, especially for children. Unfortunately, in pediatric traumatology, it is very often necessary to carry out repeated plaster mobilizations, change the type of their questionnaire, bandages, due to the fact that children are not very critical of their safety. They often get wet, and in the final we have a repeated displacement. It is not always a favorable result. Polymer plaster cast, once solidified, with all the desire after that, you and I will not get wet. In addition, there is another interesting feature: hygiene. Polymer fixing materials have porosity, that is, they are presented in the form of a solidifying mesh. Therefore, this makes it possible to ensure the evaporation of moisture and odors from the surface of the skin quite well. This is often a very serious thing, because the skin bandages in this case breathe. To be honest, removing the plaster cast, which was on the human body for 1.5–2 months, ambergris, that is, not that the stench is yes, but in itself an extremely unpleasant smell of organic decomposition is often extremely powerful and very unpleasant both for the patient himself and, of course, for medical workers. Probably, in terms of a traumatologist, this feature is the most important thing: the elastic property of the polymer material. In the right part of the slide, pay attention to a small text. Look, ensuring the complete immobility of the segment of our limb with you. 1 week of immobility and we lose 20% of muscle strength. 6 weeks, and this is a period, well, comparable to the moments of immobilization, that is, an immobilized fracture with displacement. 6 weeks, the articular bag is made rigid, and in order to perform any movement, we will need an order of magnitude more powerful effort to apply, that is, a tenfold effort. 8 weeks and mobilization. Articular cartilage at the ends of bones undergoes serious degenerative changes and may never fully recover. The ligaments lose 40% of their strength, and in the final, it will take a long time to restore the full elasticity of the ligamentous apparatus of this joint. Serious both the investment of the employment of medical workers and completely unpleasant manipulations for patients in terms of rehabilitation. So that's the beauty of polymer embolization. Elastic properties. If you take ordinary plaster, believe me, it is absolutely not elastic. Yes, it is possible in a small amount of rocking movements. If we make a little more effort, plaster bathroom, it will just break. What do we have with polymer? That is, with plastic. The elasticity is much higher and the strength is higher. This allows you to provide so-called rocking movements in the zone. That is, a small volume that cannot damage our, let's say, immobilized, but at the same time provides the possibility of any muscle contraction under the surface of the immobilizing bandage. Provides us, by the way, a fairly good outflow of fluid. That is, remember that due to muscle contraction, we have a venous return and a return, that is, the drainage function of the lymphatic system. And with all the desire, it provides a slight certain amount of rocking motion in the joints. This will make it possible to have to a lesser extent those bad ones, the bad side, the iatrogenic, let's say, the right side of our methods of treating fractures, which are called immobilized. We should probably finish talking about polymers for a long time and said that they are less toxic, especially modern polymer materials, especially those made by serious firms. Well, the pioneer here is the firm 3M, probably makes the best, highest quality polymer bandages, plus it is quite comfortable and aesthetically pleasing. They come in different colors. In my practice, there was a case when a lady with a child went on vacation to Greece. But, unfortunately, she could not postpone her rest. The child was still not needed. She broke her ankle, asked to make her a polymer plaster bandage so that she would not get wet in the sea water, and purchased a polymer plaster bandage of 3 colors. Well, guess what? White, red, blue. That is, she had a cast in the colors of the Russian flag. Greece caused a furore. This is that only Russians can be proud of their patriotism even in a state of plaster. Well, that's it. The next variant of the repositioning approach. If we were talking about manual reposition at the same time, then here it is worth saying a few words about the gradual method, that is, the method of skeletal traction. That is, a method that allows you to restore the matching of bones in a place where we cannot do it with our hands. Let's say the lower extremities. These are methods of skeletal endurance. In the classroom we will analyze in more detail. Well, the maximum that you should find out with this lecture is a nuance of terminology. Yes, that is, pay attention to the lower right corner of the bell attire. The tire is not intended for transport mobilization. These are tires for medical mobilization, on which the lower limb is placed. In the final, this will provide an elevated position of the lower limb plus the possibility of using skeletal traction throughout the lower limb. Whether it's for a heel bump, for a tuberosity greater than the tibia, or a femoral condyle. I have now listed to you the 3 main points through which the spoke is drawn. Here again, in the terminology of the Kirchner spoke, yes, which will then be clamped in a certain bracket. Here we have a Kirchner brace, an Ikobacito. And at this stage it is stretched in the body, that is, a load is suspended in the bone substance. This cargo will gradually provide us with a reposition. Methods of skeletal traction are not limited to the lower limb only. Please note, there are techniques for the upper limb here. It is not a private topic, but it is not always convenient and probably really easier to give anesthesia, especially anesthesia with a myorelaxant, and compare such a fracture simultaneously manually, yes, and sometimes by an open method, that is, directly control the location of bone fragments. Well, here there is an extension for the parietal tubercles in the lower right corner. The technique of stretching the cervical spine in the case when it is not possible to impose a more gentle thing called a glisten loop. We will talk about it with you in classes on spinal injuries. Surgical treatment, which can be attributed as the first point of our specialized treatment. Indeed, in the process of surgical treatment, we carry out the reposition under the control of vision, under the control of an interoperable X-ray machine. Yes, with its electronic optical converter, we also perform moments of immobilization. Moreover, in this case, not external immobilization is often used, which often accompanies this patient and the operated one, yes, but also mobilization through the use of implants. Implants in our case are most often metal structures created from a fairly expensive alloy with anti-corrosive properties. That is, medical steel was used before. Steel is, in fact, the same prescription stainless steel, old, ancient, used since 1914th year. Well, high quality, without unnecessary impurities. And now everything has stepped forward. Now there are many titanium-based alloys that are used in traumatology. There are many moments of combined use of metals, when the metal structure and the replacement of expensive medical steel are covered from the outside with special nanocoatings that improve its strength properties, improve its, most importantly, anti-corrosive properties. Because our body is an aggressive environment and in any case it does not accept the immersion of something alien into it. An implant is an alien thing and naturally the body fights with it, tries to destroy it. So, let's move on to the options for operational manuals using these same implants. The operation itself is called osteosynthesis. Osteosynthesis assumes that we will restore, yes, the correct design, the correct bone structure and fix it with an implant. Osteosynthesis can be submerged on the bone. Sometimes I call it extramedular, but the extramedular term itself is just it's different from the intermedular, from the following. Immersion synthesis assumes that we will, say, make certain holes in the bones and already immerse the plan that will hold the bones in these holes. For bone immersion osteosynthesis, I assume that you and I will use an implant, well, let's say with our own, let's assume a plate that will be superimposed from the outside, that is, on the bone, and the bones will be fixed with the help of those very submersible implants, which are called screws. Yes? That is, we drill holes. There are holes in the plate, screws are screwed into the bone substance. In the classroom, we will watch it, disassemble it, watch various videos. You will attend surgeries and in the final, the bone is fixed on the bone plate with screws. Sometimes we perform without a plate, just an immersion osteosynthesis. Let's say one spoke, another, and a third also performs the same functions. Screw, yes, first the hole is drilled, then, well, first the spoke is drilled, then the hole is cannulated with a drill. We will look at such operations. This is immersion synthesis. There is also a variant of intermedular osteosynthesis when the implant is already immersed in a ready-made hole, well, in this case, the channel, which is, well, our bone marrow canal, and non-focal osteosynths. Well, let's see what it is. Non-focal osteosyncrasies with you and me will be discussed in more detail in the next lecture, when we talk about open fractures to master. Immersion on bone osteosyncs. This is where we see the fracture. The fracture of the lower third of the femur is helical with the presence of a fragment. The snapshot is presented in the left part, and in the right part there is a variant of osteosynthesis. This, say, pathology, that is, an operation has been performed, a plate has been determined, a rather massive large plate that is located on the surface of the lower third of the femur. It is fixed with a large number of screws, solidly, sufficiently, seriously and in terms of strength properties, and we have restored the integrity of the bone. Such a plate, in essence, should not stand in the body forever. It is alien and having fulfilled its function, ensuring the rotation of the fracture, in most cases the plates are removed after a year by repeated surgery, that is, they are removed from a person, sometimes, in some cases, either when very high quality material is used, or when a person is elderly, or simply when a person does not want to. The plates remain in the person. There is a risk of complications with all the desire. This is an alien construct, it can cause rejection. There is even a certain term for a disease called metallosis, that is, when something like an inflammatory reaction and rejection of a metal structure occurs. Here is a video on a dummy for performing the same extramedular, that is, on the bone. That is, well, in this case, osteosynthesis. Now we'll see. Here, pay attention, that is, with the help of the costa holder, the bone fragments are fixed. The hole has been drilled. That is, in one fragment they drilled it with a thicker drill bit, then with a thinner drill bit and twisted the screw. Submersible osteosynthesis with a screw. He ensured that two fragments were pulled together. Pay attention, that's how they are fixed. On the bone osteosynthesis plate with screws. We took the plate, took the patterns, considering that our bones are still uneven. See, there is a certain bend. With the help of a pattern, the bend of the bone was repeated. Comparing the patterns with a plate and, well, say a heavy tool with pliers, they ensured the bending of the correct plate. And now the plate will be secured with screws on the surface of the bone. That's it. That's the way. In the classroom, we will consider such operations not only on dummies, but also on a person. Well, for clarity, some options will be in the form of animation disassembled for classes. Intermedular osteosynthesis. Well, the history has about the same amount of high-density synthesis. To be honest, rummage in my archives, somewhere I have a video of intermedular osteosynthesis made in the 37th year in fascist Germany, a black and white video, well, very peculiar, naturally in German. Probably now as an educational in terms of this is not an interesting video. Well, pay attention to the X-ray. On the left, we have a fracture of the shin bones at the same level, that is, it was probably a traffic accident, that is, the person was hit by a car. It is at the level of the middle lower third that we have a fracture of both bones of the lower leg and more of the tibia and fibula. The supporting function is carried by more of the tibia, so ensuring its proper fusion is the main goal of treatment. That is, intermedular osteosynthesis involves immersion into the medullary canal larger than the tibia, nail. Sometimes this is called a pin. Yes, that's the name of the metal structure. Modern methods of intermedular osteosynthesis involve not just hammering in, say, a rough, heavy, large metal structure, but also fixing it there. Therefore, the design is most often smooth, even. But you see, in the right picture there is a transversely positioned screw. This is the so-called blocking, and by itself intermedular osteosynthesis. This is called intermedular osteosynthesis with blocking. This block assumes that we will avoid not only, say, slopes in the fracture zone, that is, curvature at an angle, but it provides us with the impossibility of rotational displacement and the impossibility of displacement in width. That is, such a structure cannot disperse, because from above, and here it did not get into the picture, the metal structure is also blocked by using a transverse screw. Let's look at all this again with the help of animation. Yes, here we have a femoral fracture. Here we have a drilling of the bone marrow canal in order for it to be of the same diameter throughout. They dive in there. Yes, indeed, with the help of a hammer. After all, this is serious with us. We use a large metal structure. She sits down very tightly. The nail is immersed there and blocking is provided in the proximal and distal areas. In this case, we have stable intermedular osteosynthesis. It cannot fall apart, it cannot shift. And often people with this kind of osteosynthesis of the femur are released without external mobilization, without plaster splints. Yes, they are limited in load. Yes, they are supposed to have a fairly long period of bed rest, but the quality of life without any different external, let's say, external plaster casts, of course, is much better. And people recover faster and feel their illness less burdensome for themselves and others. In it, the focal compression destruction apparatus is presented here. This is a classic Ilizarov apparatus which is well known, widely known in our country, was developed by us. We will talk about hardware methods of external fixation in the next lecture. Well, just a few words that say that the method is really interesting, but the method is very unpleasant for the patient. The quality of life is deteriorating extremely badly. It is very inconvenient to live in such devices. A man. There is no way to leave the house, it is limited in terms of movement in space. Plus, an obvious focus, let's say, the presence of spokes passing through the skin is an open gate of infection. That is, the patient himself must necessarily treat these areas daily. He is afraid of the development of the disease, because an infection can get through these passing spokes or rots through the skin. But there are also advantages. The advantages are quite serious. Metal structures are carried out not in the area of bone damage, but away from it, above and below. This allows us to apply this method in open fractures, when we have a wound in the area of bone injury, and sometimes infected early, sometimes contaminated early. Then, of course, no implant can be placed on such a wound. This is a direct road to the development of really serious CYP complications. So, the technique of extrafocal osteosynthesis allows you to fix such a bone and at the same time not to carry out metal structures through a septic focus. In addition, the compression distraction name of this one, which is found here in the title of this slide, suggests that this method allows, if necessary, to ensure the pressure of bone fragments among themselves, than to accelerate, say, their consolidation of fusion. And in some cases, if there is such a need, to ensure the separation of bone fragments, which will allow us, in terms of orthopedic impact, for example, to restore the length of the limb. Well, pay attention, various other types of devices, external fixation devices, not necessarily on here, there is a dummy on the bone, but the device is presented. Here the spokes of the rod apparatus are combined on the top right. You see, semi-rings are also used, through which the spokes and rods pass. A radiograph showing an external fixation device for a fractured hand. And here is an absolutely terrible really structure that allows us to fix both the pelvis and fractures of the lower limb externally. Now, you see, the right hip is fixed with a rod apparatus. Well, in this case, with such serious injuries, there is no other way. Indications. Indications for surgery, in this case for osteosynthesis, can be absolute for surgical treatment and relative. Believe me, in traumatology in most cases we are faced with relative indications. Most of the traumas in traumatology can be cured with all survival both with the help of conservative treatment methods and with the help of surgical techniques. So, absolute readings. Open fractures. With all the desire, the presence of a wound is a reason to perform primary surgical treatment. And the presence of damaged organs in the wound, in particular bones, suggests that work on them. Damage to vital important organs by bone fragments, yes, substances of the brain, spinal cord, chest and abdominal organs, large vessels, nerves. In this case, surgical intervention is inevitable. Another type of fracture, or rather a complication of fractures, is the interposition of soft tissues. A condition where soft tissues appear between the bone fragments, let's say a fascia, a tendon, a muscle. In this case, to say that such a fracture can heal, but it is not possible. There will be large, serious, let's say, increases in terms with the subsequent possible development of a false joint. Therefore, in this case we have the need to perform surgical treatment. I have already mentioned the term false joint, I'll tell you about him again. That is, not the fusion of bone fragments with the formation of a false joint is treated only promptly. These are absolute indications for surgery. Purulent inflammatory complication in the fracture zone. Like any purulent infection, in this case, an operation is performed to carry out the outflow of this purulent contents. Therefore, this is an operation. Well, incorrectly fused fractures with a gross violation of the function of the organ. That is, by curvature, with shortening. That's all. Making money to restore a full-fledged function often requires a subsequent, sometimes repeated operation. So, in addition to absolute indications for surgical treatment of fractures, there are also relative indications. And they are used, by the way, quite often. What applies to them? This is a failed multiple attempt to compare, to rehearse bone fragments, that is, our failed conservative attempts at treatment. The moment of delayed consolidation of a fracture often requires, with all the desire, surgical, and sometimes the second and third time, that is, surgical treatment. Fractures of long tubular bones that cannot be matched or it is difficult to hold bone fragments. This is a fairly frequent reason for performing an operational manual, that is, for synthesis. Remember when we discussed with you a few slides ago, but quite a lot of slides, classification options. We talked about easy to hold and hard to hold fractures. So those very hard to hold fractures are the reason, or rather relatively the reason for performing osteosynthesis. Well, the fourth indication is incorrectly fused fractures with a slight violation of the functions of the organ. Well, in this case, it is often with a slight curvature or shortening of the limbs. In this case, relatively it requires surgical treatment, sometimes for cosmetic purposes, sometimes to ensure, say, the prevention of subsequent complications in our body. The third stage of fracture treatment is the so-called follow-up and rehabilitation. This stage is performed most often on an outpatient basis, and less often, patients are rehospitalized. Sometimes patients are sent to a sanatorium-type institution, where in the final plan, of course, the conditions for rehabilitation are much greater. The essence of outpatient follow-up is monitoring the condition of our limb. This is strict, say, compliance with requirements and mobilization. That is, and the requirements are both directly for quality and mobilization, yes, for tracking its viability, and for meeting deadlines and mobilization. Control in this case is most often carried out radiologically, sometimes through our methods of immobilization, that is, through a plaster questionnaire, a plaster bandage. We perform control shots. Assessing the comparison of the limb, assessing the consolidation, we can come to the conclusion that it is necessary to remove the immobilization, and in this case after that say that it is not required and it makes sense to carry out rehabilitation measures. Rehabilitation measures most often include physical therapy. Sometimes it is called kinesiotherapy. That is, we must restore the functions of the joints again, yes, bring the volume of movements back to normal, and, accordingly, restore our static dynamic function. Again, as I said, for the brush to grasp the holding function. Physical therapy is an aid to performing kinesiotherapy. That is, physiotherapy methods are very widely and actively used at the stage of rehabilitation in traumatology. This allows us to significantly speed up, yes, the moments of our patient's recovery with you. Of the physiotherapeutic methods, magnetotherapy methods are most actively used in the traumatology of post-treatment. They actively use methods of stimulating our muscular activity with currents. In particular, this is amplipulse therapy, that is, sinusoidally modeled currents. These are diadynamic currents. Thermal techniques are widely used. Yes, in particular, paraffin therapy was actively used before, but now even at home, the patient may be recommended to perform warm baths. This is a very frequent appointment in traumatology for further treatment and subsequent independent physical therapy. But the physical therapy instructor, that is, the kinesiotherapist, already in the medical institution evaluates the quality of these methods of physical therapy performed and says that the patient is in speed or is about to reach the situation that he can be discharged and assigned the status of healthy. What are the outcomes of the treatment of bone prions? The first outcome is the most optimal and good for him. It is a complete restoration of the anatomical integrity and function of the limb. The person is healthy, is discharged and can start a normal life. Another outcome is the complete restoration of anatomical integrity with a violation of organ function due to, well, let's say, muscle atrophy, the development of stiffness or contracture and joints. Sometimes these violations are temporary. Yes, the patient, of course, is experiencing difficulties. Sometimes this situation leads to his permanent disability and even to the receipt of a disability group. But most often this disability is temporary, and after 1 or 2 years of sufficiently high-quality rehabilitation measures, the function is restored, the disability is removed and the patient accepts the opportunity to live a normal life. The third outcome is probably a very unpleasant outcome when there is an incorrect fusion of the fracture with a change in the shape of the bone, with shortening, curvature of the limb, with a violation of the function of this limb, with the development of, say, lameness or restriction of movement. Such a situation, of course, most often leads to persistent disability, often to its lifelong form of disability. And patients, remaining disabled, of course suffer. And they suffer from a violation of the self-service function, and in general in terms of socialization. Slightly less dangerous and unpleasant are improperly fused fractures, but with the restoration of limb function. Well, in this case, of course, div expertiser assess such a situation, but in most cases people live quietly. Such cases are not isolated. Another outcome is the development of a false joint, that is, a non-fused fracture. Quite a formidable cooling. Now a few slides will be devoted to this, which is treated exclusively by surgical methods. And in the future, of course, the right good outcome is desirable. But most often, after such non-fused fractures, we have consequences. Consequences in the form of any functional disorders. And another unpleasant and threatening outcome is the development of post-traumatic osteomyelitis, chronic post-traumatic osteomyelitis, an extremely unpleasant disease, a disabling disease that requires long-term treatment, often stretching for years. The next lecture will be devoted to this. Yes, the post-traumatic osteoma elite. Once again, let's trace the formation of a callus by itself. That is, a hematoma was formed at the site of the fracture. Here we see it with you on the first left, well, let's say, the left illustration. Vessels begin to grow into it, they germinate, the phenomenon of regeneration begins, yes, the primary bone formation begins, the so-called bone callus, about which we have already spoken, begins to form. Corn. The callus may be periosteal. They also say it's an external bone callus. It is mainly formed due to the periosteum. It can be endosteal, just in the area where we have a bone marrow canal. We have an indolo. A callus can also form from it, and for a certain period of time in the area of fracture fusion, the lumen of the bone marrow canal itself can overgrow. The most high-quality, most durable and necessary corns is an intermediate corn, that is, a corn that fills a gap at the junction of a compact substance. Therefore, the correct reposition, dense, qualitative comparison of bone fragments leads to the fact that the intermediate callus develops quickly and it is the most qualitative. It provides a very strong fusion of bone fragments. Well, pay attention to the regionogram. Here are various types of bone callus, starting from the callus that forms here in the left picture when I incorrectly trepanize us with digestion. Yes, that is, the callus is quite coarse, extensive, at the moment not fully assimilated. And in itself, the outcome, as we said in this case, will be the same when we have an improperly fused fracture with a violation of our functions. In this case we have shoulder zones. The following matchmakers assume, you see, the quality of the performed osteosynthesis, intermedular osteosynthesis with a lockable nail. And if in the middle picture we still do not find a fully falsified corn, then in the right picture we see a fairly dense, high-quality corn, and in this case we can say that the fracture has fused and additional fixation methods can essentially be removed. Unfortunately, the process of costa-regeneration does not always go well. It does not always go smoothly, and there are various options for incorrect, say, healing of the costa of the substance. Here they are presented here. This is a slow consolidation. The concept of delayed consolidation is rather relative. The timing of fractures is individual for each person. Yes, but with all the desire, there is some kind of definite, let's say, dependence on age, on the size of the bone, on its, well, respectively, even anatomical location, that is, up to the timing of the type and nature of the fracture to the timing of its fusion. Here, exceeding the standard deadlines is commonly called delayed consolidation in our country. In the future, a more difficult, unpleasant situation is when we have a non-fused translation. When all the reasonable deadlines that allowed us to grow together had already passed and we finally found that the critical junctures. The finale of this action may be the development of a false joint. Let's talk about them a little later. Well, another of the phenomena that is completely wrong, of course, is the presence of a bone defect, when discussed was not even supposed to be these speeches at all, because we either have no bone in itself, or the bone defect is so large that the cost of calls simply do not compare with each other and initially they cannot grow together. So, the causes of fracture healing disorders may be different. These may be various common causes, that is, for example, serious systemic diseases, such as diabetes. It's not a disease, but a condition. This is a physiological condition of a person, pregnancy, yes, but a condition that requires high calcium requirements for a pregnant woman, and in the case of fractures in a pregnant woman, the terms are often much longer and the fractures heal worse. Serious diseases that cover the entire body, such as, for example, radiation sickness, as various variants of anemic conditions. This is vitamin deficiency. In this case, we can say that there are common problems of bone fusion, and healing, of course, will be slowed down. In addition, in most cases, it is somewhere on average in 90% of cases, local factors lead to non-fusion of the fracture, and sometimes to the formation of a false joint. Here are listed the most specific causes, yes, bone healing disorders, bone fusion disorders. So, the first is an insufficient reposition of fragments, that is, poorly executed reposition, when they are poorly compared with each other, will of course lead to the fact that such a fracture will take longer to fuse. Ineffective external mobilization, as by the look of the bandage, yes, that is so. That is, when, let's say it is incorrectly imposed, not the one that followed. So is the duration of fixation. That is, early withdrawal in this case may lead to the fact that mobilization is inherently ineffective. It is not completed at the right time for the right actions. And this leads to the fact that loose with the zodiperion does not allow the bone marrow to form correctly. Repeated unjustified attempts to correct the fragments are quite traumatic procedures both for the bone substance itself and for the adjacent soft tissues, namely, subsequently disrupting the blood supply to this zone. Of course, after some time, such fractures will also affect, which, well, let's say, were subjected to subsequent repositions, yes, they heal, of course, worse. One of the most unpleasant situations that lead to non-healing of fractures, and very often to the development of a false joint, is the interposition of soft tissues. When soft tissues, in particular, are most often fascia, these are various ligamentous elements, these are muscles. They fall into the lumen between the bone fragments. This situation is not monitored properly, that is, on the X-ray, all this is regarded as a satisfactory comparison of fragments and fusion does not occur in this case. The next cause of the healing disorder may be concomitant damage to blood vessels and nerves. Moreover, not only as a mechanical damage, but also various moments, for example, thrombotic cooling in the fracture zone. This is the development of various neuritis and neuropathy of a post-traumatic nature. These things can delay the procedure of fusion and healing for an extremely long time. Well, an incorrectly performed operation, that is, an unstable osteoarthrosis, when we fix the bones with implants for good reasons and at the same time the implant we use is of poor quality, the bone fragments are not retained in this area, can lead the whole thing to disgust. The return of the next moment is diastasis between the fragments during treatment by permanent skeletal traction or after osteosin. That is, we compared the fragments in such a way and fixed them on osteosynthesis, which initially created a diastasis, that is, a gap between the fragments. This gap requires a sufficiently long overgrowth and, as a result, narrowly lengthening the terms of fusion. Unjustifiably extensive removal of fragments with the formation of a bone defect. Early removal of the retainer. Sports medicine often sins with this, when in an attempt to provide and restore the functionality of the patient as quickly as possible, that is, to return him as an athlete to the system, quite often, despite the traditional deadlines, they try to shorten them as early as possible to remove the fixator, and sometimes the finale is very good moments for me, which most often lead to refractures, that is, to repeated fractures of the VTZ. Absence of external immobilization in unstable osteosynthesis. Remember, when we talked about intermedular osteosynthesis with blocking, for example, for the femur, a few sways ago and considered an animation there, let's say, a cartoon, then we said that the method is stable. The method is so durable that it allows the patient to stay in the period of further treatment without external immobilization. So, it's not always good. Sometimes the osteosync method is used, which is not fully stable, and external fixation is not used. And such fractures take a long time to heal. Absence of periosteum and insufficient blood supply. This is already a feature of our organism. That is, there are a number of fractures, more precisely, zones in our body that initially do not suggest the possibility of the development of periosteal corns. Let's say this is the femoral neck, this is the palm bone of the hand. These are the zones. The palmar bone itself is initially like this, and the femoral neck is simply anatomically located in such a way that it is an intra-articular formation when we do not have periosteum and we do not have periosteal calluses. We said, yes, indeed, periosteal and endostal corns are not the most necessary, not the most durable formation. Of course, it is the intermediate corn that is ideal. Well, in this case, the absence of these calluses leads to the fact that such fractures are initially considered to heal for a longer time. On the issue of non-fusion of fractures. Yes, when consolidation is considered slow and fusion does not occur, they talk about the development of, let's say, a non-fused fracture. A constant moment of mobility in the area of an ungrown fracture can lead to the development of a false joint. It is customary to separate false joints. There are congenital false joints, which are depicted here in this illustration, yes, pseudoarthrosis. In this case, a false joint develops as a result of intrauterine disorders of bone formation. A rather complex orthopedic pathology which leads to the fact that a child born cannot fully, let's say, use his musculoskeletal system, and from birth he is already sentenced to the most serious operations, because a false joint, whether congenital, well, and accordingly acquired, and is treated only surgically. That's such an unpleasant thing in pediatric orthopedics. There are pseudoarthrosis joints, there are acquired false joints. Acquired false joints, naturally, this is a post-traumatic complication. They can be hypertrophic, atrophic, trophic norms. This is directly in its structure, yes. A characteristic symptom of false joints is pathological mobility of the bone and in its unusual part, most often throughout the diaphysis. The degree of mobility is absolutely different from barely noticeable movements to movements with a large amplitude, and in some cases, clinically, this is still manifested by symptoms. That is, these are painful movements. Relying on such an ungrown limb is often extremely painful, that is, with an axial load. When establishing the diagnosis of a false joint itself, it is very strongly and qualitatively oriented precisely on the timing and on radiographic studies. We'll talk about them a little later, but for the timing and reasons for acquiring a false joint, let's look at this slide. The reasons for what may be the development of false joints. This is the divergence of bone fragments after their reposition. This is not a high-quality embolization or damage to it. And sometimes the damage in this case is on the one hand intentional, unintentional on the part of the patient, but insufficient control over the quality of mobilization, negligent approach of medical workers, or, say, the patient's belief that he is doing well, can often lead to the fact that we will not find the fusion of the fracture and the development as a result false joint. An excessively early load on the damaged segments of the limbs, as we have already said. I have said this more than once, again for the sake of the same sport or some other positions. For example, in the life of a patient, we cripple him. Purulent inflammatory complications, suppuration in the fracture zone very often leads to complete non-fusion of the bone and the development of a false joint. There is a violation of blood supply to bone fragments. Yes, that is, initially the most serious injury with damage to the main vessel in the final can lead to the fact that in this zone even qualitatively matched bone fragments may not fuse. Well, the most common reason, again, I say this at the last wedding, is the interposition of soft tissues. That is, a poorly executed reposition, the lack of, say, clinical flair at this moment. That is, well, roughly speaking, the negligent forgetfulness of the doctor that such a situation is possible can lead to the development of a false joint. Practical manifestations. The most accurate and reliable can be said about the development of a false joint. According to the clinic, we discussed with you that the deadlines are lengthening. If the deadline is beyond reasonable, we are talking about slow consolidation. If the term exceeds twice the period required for fusion, we are talking about an ungrown joint. If the period of non-fusion continues further, look for the development of a false joint. And how to find him? Here we have an X-ray here. What can we see in the fracture zone? Absence of a callus. That is, the periosteal callus is most actively visible and it is not present. Yes, that is, the ends of both fragments do not connect. Not only does it not connect, they begin to round off and smooth out the ends of the bone fragments. If they take a conical shape, then we need to talk about an atrophic false joint. If there is a thickening at the ends of the bones in the zone, then well, something like an epiphysis begins to break, then we can talk about a hypertrophic false joint. Often the end of one fragment begins to have a hemispherical shape and begins to resemble a head, that is, it is convex. But the other end begins to have a concave shape, that is, something like a joint begins to form a joint gap. The so-called neoarthrosis, yes, that is, the zone of non-aversion begins to represent the shape of the joint. Plus, the bone marrow cavities of the canal begin to overgrow in winter, yes, that is, the so-called false closure plates form above and below this fracture site, the bone marrow canal begins to originate. All this may indicate that we are faced with the formation of a false joint and it is difficult to treat it, difficult. The duration of treatment is stretched over a huge period and treatment is exclusively surgical. Improperly developed tissue must be excised by performing an osteotomy. It is necessary to fix this joint, or rather a false joint, this area of the fracture. And considering that there is an improperly developed tissue in this zone. Sometimes this zone is infected, because we said that one of the reasons is the development of the same purulent sleeping cooling, that is, the elite, then very often use external fixation devices. When we disassembled them, well, a few slides ago, we mentioned the situation that external fixation devices allow us to set such a thing as compression. And indeed, here it is a very positive side of this method of treatment. That is, as Elizarov himself said, who invented the Elizarov apparatus, that is, that the false joint burns in the fire of compression. That is, we squeeze the bone tissue, we flatten the incorrectly fused, neutrally formed connective tissue. In this place, processes begin to occur that are already characteristic of proper bone formation, which are presented here. The clinical cases themselves are presented, and from below, even if it is not very qualitatively visible, but the use of various methods of immobilization, various methods of osteosynthesis, more precisely, most often, depending on nothing, osteosynthesis is followed by positive in false joints. A long process that takes months. We will have very little time left for the next part of our lecture. We'll sort out the dislocations. In Latin, the dislocation is called luxatio. This is a persistent abnormal displacement of the articular ends of the bones in relation to each other. A partial displacement, but not completely, say, not significantly, is called a succession under dislocation. It should be borne in mind that dislocation is a much more dangerous injury if we are talking about traumatic dislocations. But here we are faced with the classification that dislocations can be congenital, that is, injuries. That is, an innate milestone is not more of a trauma, it is more of some kind of underdevelopment. You and I, in the scope of our classes with you, will analyze the congenital dislocation of the hip. Plus, you will probably actively report on this topic as an examination of our answer in the section Pediatric Surgery, Hospital Surgery, Pediatric Surgery to Sergei Genadievich. You will have it with you on the floor of the 6th, yes, in the middle of the winter session of the 6th year. But traumatically acquired milestones are the most serious injury. Moreover, these fractures can be divided into traumatic ones, as a result of excessive mechanical action, and pathological, when initially there is a pathology in the joint area, for example, a tumor of some characteristic formation, of an inflammatory nature. Let's say a purulent inflammatory process that destroyed the capsule of the joint. In the final we have a dislocation. Dislocations, according to the classification, depending on the timing, it is customary to divide them into fresh, that is, when the patient comes to you and the period does not exceed 3 days from the moment of its receipt, into not fresh, that is, it is 3 to 4 weeks. That's the first and second dislocation. There is still an opportunity to fix it conservatively. Of course, for stale dislocations, there is a risk that we will not be able to correct by conservative methods. Well, serious. Sometimes you have to operate on such patients. Old dislocations, when more than a month has passed at the top, that is, an early old one is up to 3 months and it is almost impossible to fix it. And the post is not old for a period of more than 3 months. There is even no point in trying to carry out such measures, because we have a soft tissue wound as such, the capsule has already healed, that is, a non-woven structure has already formed, which simply will not allow us to properly restore and correct this particular cut. Of course, such dislocations are already subject to surgical treatment and often a very long complex operation. So, dislocations, as I have already said, are a situation that is much worse in terms of clinical prognosis, in terms of, say, the clinic itself for the patient, than a fracture. Why? Because we talked about bone tissue regeneration a few days ago. The body has come up with a regeneration system. She is actively working. She's doing a wonderful job. In a young body very quickly. In an elderly, even extremely elderly and dilapidated organism, people who are more than 100 years old, and even then, the possibility of rotation of the bone substance, it works out. But they are accompanied by dislocations in the majority of their soft tissue damage. This is a rupture of the capsule of the joint, a rupture of the ligamentous apparatus. Yes, at the same time, one of the articular surfaces exits through the rupture of the capsule. As such a wound is more painful. The capsule is very well and efficiently energized. Such a wound requires long-term healing with the formation of connective tissue, then coarse tissue, which in the future will not be as high quality and elastic as normal proper capsules, as normal, say, correct ligaments of the body. Dislocations in the upper limb are more often observed. More than half of all dislocations of our body occur at the shoulder joint. That's 55%. A quarter of dislocations are dislocations in the area of the elbow joint. Now we will talk with you about the correct names of dislocation on the following slides, but for now we are taking into account the anatomical location of that place of pathology. The joints of the hand are 9%. The rest, of course, already falls on well, other joints, on the lower limb, and so on. Depending on the attitude to the external environment, there may also exist, well, in most cases, overwhelmingly it is a closed dislocation. But the moment of open dislocation is not excluded, when soft tissue damage occurs either at the time of injury in the joint area, or that this is also possible with extremely pronounced mechanical action from the inside, but there is a rupture of the soft tissue capsule up to damage to the integumentary tissues. Dislocations can be accompanied by the same rough sedimentation as fractures. That is, these are called dislocations with damage to the neurovascular bundles, with a fracture of the epiphyses. And we are talking in this case about fractures of dislocations, and in the future, an option is possible if we have wounds, that is, it is with purulent inflammatory complications, mostly of course it is open VYH. Well, in most cases we meet uncomplicated dislocations. Factors contributing to the occurrence of dislocation. The shape of the articular surfaces. Remember, we said that 55% is our shoulder dislocation, right? That is, dislocation in the area near the joint. The joint itself suggests that it is a very mobile joint with a large degree of freedom. With an insignificant volume of articular surfaces compared with each other, and most of the head, that is, it freely exists. This is the shape of the joints and contributes to the fact that this joint is more often embedded. Weakness of the ligamentous apparatus. But this is an individual feature of people, therefore, it is possible to initially link, for example, the situation with hybridus. That is, if people do not do physical education and sports in the course of their lives, they are weak, then the risk of dislocations is much higher. The age of the patient. In old age, of course, the risk of dislocation is much higher. About the small area of contact and joints and about the shape of the joints, I'm telling you, yes, a spherical joint is much easier to mow. And the moment of a large volume of joint movement. If we assume that there is active movement in this joint, then, accordingly, the chances that it will dislocate are greater. Depending on the purity, the primary dislocation is isolated, which happened here at the same time, now it is. And the usual dislocation. Habitual dislocation is a pathology that assumes that dislocation in the same place, in the same joint, in the same direction occurs repeatedly. That is, the bottom line is that the damage to the capsules of the joints is either not fully overgrown and not alive. And in the final we show a repetition of such cases. Definitely pay attention if, for example, the patient had an anterior dislocation, say, of the shoulder, and a few years later a posterior dislocation occurred. This cannot be interpreted as habitual. This is unambiguously interpreted as the situation that it happened again primary traumatic. Now, according to our terminology, let's talk. This is the scourge and misfortune of all our students. For some reason you can't remember it. The peripheral part is considered dislocated, that is, the peripheral bone, the peripheral segment, and the dislocation is named exactly by the name of the functional segment there, where this bone is located. That is, it is correct to talk about dislocation of the shoulder, dislocation of the forearm, dislocations of the hand, dislocations of the hip, dislocations of the lower leg, dislocations of the foot, dislocations, for example, the middle phalanges of the second finger segment, the entire phalanx is dislocated. There is an exception, the collarbone. Here there are the terms dislocations of the criminal end and dislocation of the thoracic end. And that's why we say in the classroom that such terminology is not always welcomed by all traumatologists. Very often, many people deliberately, consciously dislocation of the criminal end of the clavicle is called a rupture of the criminal clavicular joint. Catch the breast end. This is a rupture of the sternum of the clavicular joint. There are a number of joints difficult, involving more than 2 bones. And here, too, there are its own peculiarities. For the watch joint there is a separate term, dislocation of the head of the radius. Yes, that is, in a better shoulder joint, where the head is concave, adjacent to the cephalic elevation of the distal epiphysis of the humerus, it is customary to talk about dislocation of the head of the radius. But the situation where the block-shaped joint of the ulna, yes, clings to its, let's say, formation in the form of an ulnar process and an eternal process for a block on the distal epiphysis of the humerus, they are already talking about dislocation of the forearm. Let's say a dislocation of the patella. This is a sesamoid bone, yes, in the knee joint, which can dislocate to the right, to the left, that is, to the side, inwards, outwards. They speak separately on such a sweat as a dislocation of the patella. For the spine, dislocation is named after the overlying vertebra. We will sort it out with you in the classroom, talk about terms or STES, yes, that is, lists is an identified displacement of one vertebra in relation to another, mainly revealed during X-ray diagnostics. And dislocation. And a dislocation is it's an injury. This is a process of mechanical action, yes, with a clinic with a certain bad and which leads to a displacement of the spine. Relative symptoms. That is, the symptoms, that is, we have unreliable, probable signs of dislocation. Constant severe pain in the joint, even at rest, intensifying with any movement, forced position of the limb, which is painful enough to change. That is, it does not work to change it, the pain increases very materially for the patient. A change in the length of the limb, yes, swelling in the joint area, the presence of bruises. These are relative symptoms. There are absolute, that is, reliable symptoms of dislocation. This is a complete lack of movement in the joint, and when trying to change the position of the limb, there is a feeling of springy resistance by passive movement. Here is a reliable absolutely symptom. Well, the variant of deformation in the joint area with smoothing and sinking, with dips, the so-called symptom of umbilication. This situation is our absolute symptoms. Here, pay attention, a photo of a child. He has a soft tissue in the area of the shoulder joint, just in the form of a navel. There is a symptom of umbilication. Moments of diagnosis of dislocations. Well, simple enough. Yes, the same moments as, that is, we talked about physical nuances with you. Of course, palpatory soreness during examination is swelling, a clearly detectable nuance of deformation, umbilication, and so on. And additional methods of radiography. Moreover, it is often performed not only as a goal of diagnosis and confirmation of dislocation, but as a situation to prove the absence of concomitant fractures after the correction of the control geography confirms the qualitative comparison of articular surfaces in the joint area, as well as the absence of caused, again, a fracture, because the moment of correction is quite high energy nuances. And most often the risk of fractures in this case is very high. Here on this slide we see with you a radiograph of the shoulder joint of a direct projection, and here we see a dislocation of the shoulder. That is, we do not compare the articular surface of the scapula and the articular surface of the head of the humerus. The stages of treatment of dislocations are the same as in the treatment of fractures. That is, there is a pre-hospital stage, which in most cases is associated with certain difficulties. This is due to the fact that dislocation of a large joint is an extremely painful situation. A person does not find a place for himself, the pain is constant, with any attempt to move the pain intensifies. It is quite difficult to mobilize such patients, because they often take a very peculiar position, incorrectly positioning their limbs in a position in which they are really more comfortable and less painful. In such a situation, it is very difficult to carry out mobilization. Kramer's tires were very active here at the time, which made it possible to model this case in different positions. The second stage is the provision of specialized trauma care. Let's talk about it now, and, accordingly, the moment of the slightest rehabilitation is very similar to the same nuance in the treatment of fractures. So, before the hospital, as we have already said, anesthesia, narcotic, non-narcotic energy. All this is due to the intensity of the pain syndrome and mobilization, which with their difficulties and careful transportation of the patient to the right place. Where are the patients transported? Where will that specialized assistance be provided? Quite often, the patient is taken to an outpatient facility, that is, to an emergency room. There are nuances and absurdities here. The situation with dislocations of large joints suggests a very painful mechanism of reduction. The painful mechanism of government, the pain itself is stopped only by general analgesia. Hence the conclusion that it is impossible to perform it in an outpatient clinic. Therefore, dislocation of the shoulder, dislocation of the hip, dislocation of the lower leg, dislocation of the forearm is often the lot of the hospital. Any dislocations in childhood are the lot of the hospital. Only there can general anesthesia be performed. Dislocations of the shoulder, here is the most frequent in old age, after 60 years. In this case, it is quite often performed in the ward in an outpatient clinic, because the risk from, let's say, general anesthesia is greater. But with all the desire, it is still desirable to have a hospital, the presence of accompanying specialists of a full-fledged volume, if necessary, the provision of rehabilitation benefits. So, specialized care is an early recovery after adequate anesthesia. The earlier the management is carried out, the easier the situation will be to perform this thing and the more chances for high-quality healing, restoration of functions. After reduction, this is the immobilization of the limb in a functionally advantageous position for an adequate period, for a period of at least 3 weeks. Even in a child, soft tissues do not heal faster than 3 weeks. The ideal option, for example, for a dislocation of the shoulder is a 4-week period. A 3-week period is enough for the fingers of the hand. There was a huge variety of methods of government. Here in history, various frescoes, drawings, paintings suggest that this situation was described with different people, starting from the rack, which are represented here in ancient paintings of ancient Greece. See how a man was hung upside down. Or in medieval engravings, when you see here, either a person was outweighed through a vertical beam, or stretched on such a special device. Of course, it's really scary and unpleasant. The dislocation technique is described in the writings of Hippocrates and, as you understand, it is more than 2,000 years old, and this technique is presented here on the left in such an illustration. When the heel is bare, the ancient Greek heel of the doctor is located in the area of the armpit and traction is carried out. That is, the limb is pulled into the upper one, it is withdrawn, brought, rotated. At this moment, the departure is carried out. The Hippocratic method itself is probably one of the most ancient trauma manuals that are actually recorded on paper. Methods of shoulder reduction as the most frequent dislocation. We will analyze others with you in practical classes. Here are different of them, and the method of Hippocrates, and the method of Janelids, yes, and the method of correction according to, let's say, Mukin on the modification of Moto, but in the sitting position are also very peculiar techniques. Methods of reduction of hip dislocations. Here are the pictures drawn. To some extent, they are really wrong already. Dislocation of the hip can be corrected without anesthesia at the moment. Well, probably not in any way. If only it will be a habitual dislocation, and this is a huge rarity, just huge. Therefore, hip dislocations, of course, are the lot of big anesthesiology. This is intubation, these are myorelaxants. But the technique itself has not gone away. Here, if the Janelids method is presented on the left and it is difficult to implement it under anesthesia when the patient is lying on his stomach, then here is the Cocker method, which is presented on the top right with you and me. Well, let's say, one of the most commonly used in the treatment of hip dislocations. Indications for cooperative treatment. It is not always possible to correct dislocations conservatively, so the indications are open dislocations, that is, at the same time, the primary surgical treatment of the wound is performed, the dislocation is eliminated, the joint capsule is restored, and the skin is sutured directly in the area of damage. When interposing soft tissues, it is also necessary to perform an operational manual. An open surgical reduction is provided with the elimination of those most interposed, that is, those that got inside the soft tissues that did not allow the correct comparison of articular surfaces to recover. Long-standing dislocations, and we have already talked about them, conservative ones practically cannot cope. There is an open reduction of dislocation and restoration of joint capsules, and quite complex operational manuals are performed with us with the usual dislocations. That is, the usual dislocation suggests that this situation is already long-lasting, that the capsule of the joints that has been fully affected has never healed, that we have fragments that do not fuse together in the form of connective tissue, yes, capsule sections. As a result of, say, permanent dislocations, we have muscle atrophy in this case. Sometimes it is so serious and pronounced, and the muscles are shortened, that it is impossible to return them and restore their full volume of movement. Therefore, it is necessary to transplant the attachment points of the muscles, perform plastic surgery, suture this non-overgrown hole in the joint capsule. The procedure of pretreated rehabilitation is not much different from such a situation as we have with fractures. That is, full-fledged mobilization and subsequent gentle rehabilitation in terms of physical therapy. If necessary, the use of physiotherapy techniques is very much welcome. Well, that's it. That's enough, a long enough 2-hour lecture. What I see is that my time shows exactly 2 hours has ended. You can view it, take notes. Have a nice day. Goodbye.